Hello everyone, my name is Cameron, and for my discovery project, I decided to focus on pseudobulbar palsy to better understand this neurological condition and its impact on individuals. So what is pseudobulbar palsy? Pseudobulbar palsy is a neurological disorder that affects a person's ability to control the muscles of the mouth, face, and throat. This happens due to damage to the bilateral upper motor neurons in the corticobulbar tracts, which carries motor signals from the brain to the cranial nerves responsible for controlling these muscles. As a result, voluntary control over speech, swallowing, and facial expressions become significantly impaired. So as mentioned before, pseudobulbar palsy occurs when both sides of the corticobulbar tracts are damaged. This prevents motor signals from effectively reaching the cranial nerves that control the face, mouth, and throat. The most common cause is a stroke, but other conditions such as a traumatic brain injury, MS, ALS, brain tumors, and other neurological diseases can also lead to pseudobulbar palsy. Individuals with pseudobulbar palsy often exhibit several noticeable symptoms, including dysarthria, which is speech difficulties due to impaired muscle control, dysphagia, which is trouble swallowing, facial muscle weakness caused by spasticity, exaggerated reflexes, and emotional lability, also known as pseudobulbar affect. Pseudobulbar affect is the sudden, uncontrollable episodes of laughing or crying that may not match the actual person's emotions that they want to convey. In terms of epidemiology, pseudobulbar palsy is more common in individuals over 50, and men are affected slightly more often than women. Post-stroke pseudobulbar affect occurs in about 20% of patients after an acute stroke and in roughly 12% of those with chronic stroke, making it a relatively frequent complication in stroke populations. So here this image illustrates the difference between a normal brain, as seen in picture A, and a brain affected by pseudobulbar affect in picture B. In picture A, emotional expression is voluntary and well-regulated. The emotional motor expression network, as seen by the blue arrows, sends signals for laughing or crying, while inhibitory inputs from the motor and somatosensory cortices, as seen by the red arrows, act like brakes, controlling emotional responses. In picture B, these inhibitory signals, seen as the dotted red arrows, are damaged. The brain loses its ability to regulate laughing and crying, so essentially the brake is broken, leading to involuntary, exaggerated, and often inappropriate emotional outbursts. Damage to the corticobulbar pathways disrupts voluntary control of the bulbar muscles, often causing spastic dysarthria, which is characterized by effortful, slow, and strained speech, harsh or tight vocal quality, imprecise consonants and distorted vowels, reduced pitch and loudness, giving a monotone voice quality, and hypernasality due to velopharyngeal dysfunction. Individuals with pseudobulbar palsy often experience dysphagia, reflecting the shared neural pathways for speech and swallowing. Dysphagia presents as difficulty initiating a swallow, slow or effortful swallowing, and weak or uncoordinated tongue and lip movements. These impairments increase the risk of aspiration and choking. It's important not to confuse pseudobulbar palsy with bulbar palsy. Both affect the bulbar muscles, but the underlying causes differ. So for example, bulbar palsy occurs when there is damage to the lower motor neurons, which are the cranial nerve nuclei located in the brainstem. In contrast, pseudobulbar palsy results from damage to bilateral upper motor neurons, specifically the brain areas that control those cranial nerves. So here is a chart that I made that highlights those differences just mentioned. So as you can see, pseudobulbar palsy is caused by bilateral upper motor neuron damage, which results in spastic and tight speech, an exaggerated jaw jerk, and increased muscle tone. Conversely, bulbar palsy is caused by lower motor neuron damage, leading to nasal and weak speech, an absent jaw jerk, and decreased muscle tone.
Stick out your tongue all the way out. You go back and forth. Okay. Put it back in and say la 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 la.
La 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 la.
Say pa pa pa.
Pa 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 pa.
And say ka ka ka.
Ka ka ka.
Say ka.
Ka.
Catch.
Cat.
Okay. And just relax a little bit with your jaw. I'm just going to tap here. Just relax totally. Let it close. No, there you go. Open it just a little bit. Okay. Have a positive jaw jerk. Okay. I'm going to have you stick out your tongue, and I want you to say "ah."
Ah.
Say "ah" again.
Ah.
Okay. Let's see if we can go up close now. We can open your mouth. Say ah. Say ah again. Okay, now I'm just going to open your mouth wide. And do you feel that? Okay, all right, that's yucky. Okay. All right, it's kind of easy to gag, isn't it?
Yeah,
After watching this video, the patient seems to be showing some signs of spasticity, especially during the diadochokinetic speech tasks, with exaggerated reflexes such as the jaw jerk and speech that appears effortful, slow, and tight. The tongue moves slowly and appears coiled at times, especially deviating to the left side, with the jaw moving along with it. The palate shows limited upward movement, and the gag reflex is hyperactive, which is consistent with pseudobulbar palsy and the symptom of spastic dysarthria. Pseudobulbar palsy can greatly affect an individual's everyday life. Difficulties controlling the tongue and mouth can lead to aspiration pneumonia. Severe swallowing difficulties can lead to malnutrition and dehydration. And beyond these physical effects, speech and emotional challenges may cause social withdrawal, increasing the risk of depression and anxiety, which further reduces quality of life. So since pseudobulbar palsy is a syndrome that results from underlying brain injury, treatment is primarily compensatory, aiming to manage symptoms and improve overall function. So for when treating spastic dysarthria, speech therapy can incorporate muscle relaxation techniques and speech rate control strategies to improve clarity and intelligibility. For dysphagia treatment, it includes both compensatory and rehabilitative methods like adjusting posture, changing food textures, and doing oral motor or swallowing exercises, sometimes even using electrical stimulation. And in more severe cases, if swallowing isn't safe, a feeding tube might be needed to make sure the person gets proper nutrition and stays hydrated. For treating pseudobulbar effect, the only FDA-approved treatment is a combination of dextromethorphan and quinidine, which reduces inappropriate laughing and crying. In conclusion, pseudobulbar palsy is caused by bilateral upper motor neuron damage affecting the bulbar muscles, which include the face, mouth, and throat. Common causes include stroke, TBI, MS, ALS, and brain tumors. Symptoms include spastic or tight speech, swallowing difficulties, facial weakness, and involuntary laughing or crying. Increased risk of aspiration, malnutrition, social withdrawal, and emotional challenges, and treatment focuses on speech and swallowing therapy with medication available for managing pseudobulbar effect. So all in all, by understanding these causes, symptoms, and treatment strategies, we can better support individuals with pseudobulbar palsy in maintaining safe swallowing, effective communication, and overall quality of life.